Hi, Maroondah Dialysis. It's Hannah here, hoping you guys are well. Jill has asked me if I wouldn't mind redoing my in-service that I did last year in my grad year, just to refresh you all. And since we can't do in-person in-services at the moment, I'll pre-record this for you so you can access it at any time. Today I'll be talking about calciphylaxis. I'll be talking about what the disease is, how it develops, some treatments that we have for it, and some nursing considerations and what we can do as dialysis nurses to help treat and prevent the disease. So, calciphylaxis is a rare but deadly condition that's characterized by these painful necrotic skin wounds that you can see in the picture on the top of the slide. These skin wounds develop due to calcium deposits in the microvessels of the subcutaneous and dermis layers of the skin, which block the blood flow and cause these wounds. This condition primarily affects the end-stage renal disease population, and in particular our dialysis patients. 1 in 1,500 dialysis patients will be diagnosed with calciphylaxis. The mortality rate is incredibly high. After 1 year of diagnosis, 50% of patients will have died from the complications of calciphylaxis. One of our patients at Maroondah Dialysis has been diagnosed with this condition, so it's really important for us to refresh our knowledge about the disease and learn how we can treat and prevent the disease from happening to anyone else. So some risk factors for getting the disease, your gender. So if you're female, you're at a higher risk of developing calciphylaxis. We think that's due to the different hormones in females compared to males. Your age, so if you're over 50, you have a higher chance of developing it. If you've been on dialysis for more than 2 years, you have higher chance. Comorbidities, especially diabetes, predispose you to the disease because they can further injure the endothelial tissue, which I'll talk about in a couple of slides. And the chronic elevation of serum calcium phosphate and parathyroid hormone contribute to the disease, which I'll also talk about in the next few slides. So let's talk about why dialysis patients are at most risk of developing calciphylaxis and the environment in their bodies which predispose them to developing this disease. It's very complex and there's numerous factors at play. We still don't know a lot about it, but this is what we think usually occurs in the perfect storm. So in end-stage renal disease, we have a drop in kidney function, GFR, and this increases serum phosphate, decreases serum calcium, and decreases the amount of active vitamin D in the bloodstream. All of these trigger the thyroid gland to produce parathyroid hormone, and this increase in parathyroid hormone causes the bones to leach calcium and phosphate, more calcium and phosphate into the bloodstream. And if our kidneys were working normally, they would excrete the phosphate and retain a bit more calcium and activate vitamin D to get back to homeostasis. But of course, in end-stage renal disease, our kidneys aren't working normally, so that would not occur, and it becomes a vicious cycle, which in the end causes incredibly high amounts of phosphate, calcium, and parathyroid hormone in the blood. And it's in this environment with additional environmental factors like the chronic inflammation that we get in renal disease. There's a chronic inflammatory state in people with kidney disease, as well as the comorbidities that we talked about before, like diabetes, which increase the risk of endothelial damage, especially when it's poorly controlled due to those high sugars in the blood, as well as the increased rate of toxins that we have in kidney disease, so our increased urea and creatinine. And it's all of these factors that contribute to endothelial tissue damage and predispose for calciphylaxis. So these factors cause damage to the tissue, which predisposes the calcium deposits to stick to those tissues and eventually lead to calciphylaxis. So as I said earlier, the endothelial damage predisposes these calcium deposits to easily stick to the edges of the vessels, which causes a narrowing of the vessels, which restricts blood flow and causes ischemia to the tissues that the vessel supplies blood and oxygen to. And then this ischemia triggers an inflammatory response, and often the inflammatory mediators cause further injury to the vessels that supply the blood to these tissues, and eventually they will thrombose and block off and cause an infarction and necrosis to the tissues that those blood vessels supplied blood to. And it's this necrotic environment of the wounds that can cause infection and may lead to sepsis and death. And that's why this disease is so deadly. So what treatments have we got for calciphylaxis? Our primary treatment is sodium thiosulfate. Sodium thiosulfate works by binding and excreting to those calcium deposits and try to remove them as much as possible. This increases the blood flow to those tissues and prevents further necrosis. Sodium thiosulfate is also a vasodilator, which will open up those vessels a bit more to provide more blood flow. So it's definitely not a cure, but it works quite well to prevent any further necrosis of the tissues by increasing the blood flow to those vessels and tissues. So it slows the progression of the disease. Of course, management of our mineral bone diseases is very important to try and lower their phosphate levels and the calcium levels and the parathyroid hormones in the blood to prevent the endothelial damage. So to prevent and manage those mineral bone diseases, we can do parathyroidectomies, give Synsulet and phosphate binders, as you would already be well aware of. We do that quite a lot. Another treatment is hyperbaric oxygen therapy, which works quite well for a lot of chronic wounds, and it basically uses a pressured environment to increase oxygenation of those wounds and aid in healing. And good sterile wound care and pain management is very important in the management of calciphylaxis, ensuring that these wounds stay clean as possible and prevent any infection and thus sepsis. And as you would understand, these wounds are incredibly painful for people, so ensuring that they have good pain management to improve their quality of life. So what can we do as dialysis nurses? We can follow our nursing process. We can prevent, assess, treat, and evaluate. So in terms of prevention, the most important thing that we can do is treat mineral and bone diseases earlier to reduce that risk of endothelial tissue damage, as we talked about before. So giving our phosphate binders, checking those bloods, and most importantly, educating our patients about why it's so important to treat these mineral bone diseases earlier, take their phosphate binders, take their Synsulet, take all of those medications, and why they're taking them can really help them with actually doing it in compliance and educating them about the risks of calciphylaxis and other complications of mineral bone diseases. We can be assessing our patient's skin, so asking them if it's intact, if it's looking good, looking for any early signs of necrotic tissue, having not only asking but having a look ourselves in our yearly check of patient's skin and feet. In your primary patients, super important, and to always be assessing for signs of sepsis. So those changes in vital signs and really getting people septic treatment as early as possible if it does eventually get to that. Helping our patients with their treatment of calciphylaxis, so providing them with wound care, liaising with the wound care nurses if we're not doing it ourselves, ensuring that it's actually getting done. Administering sodium thiosulfate, so our patient at Maroondah, he had sodium thiosulfate at the end of his dialysis, so ensuring that happens every run, and of course aiding with that pain management in people who've developed the disease. and advocating for our patients always. And evaluating our care, so ensuring that we have a multidisciplinary approach, getting physio involved, getting social work involved, in pain specialists, palliative care, renal doctors, nurses, or the whole team getting together and knowing what our plan is, ensuring that we're patient-centered, we're listening to our patients, we're advocating for them, and ensuring that palliative care get involved early to preserve their quality of life, because this disease is so deadly, making sure that they get the best out of any time they have left. So that is it. I've got some references there if you guys are interested in learning any more. But thank you for listening, and I'll see you guys soon.